Okay, good afternoon, everyone, and welcome to today's Hopkins Hour, our online seminar, and it's the first for 2026. I'm Tamara Ownsworth, the Research Director at the Hopkins Centre, and it's my great pleasure to chair this Hopkins Hour on the topic of trajectories of rehabilitation across complex environments. And what we're doing today is we're showcasing some of the milestones and findings and clinical impacts of the TRACE program, which has been running now for several years. So I'd like to extend a warm welcome to all Hopkins members, partners and collaborators. And I'd like to begin by acknowledging the traditional custodians on the lands on which we meet today virtually, and I'd like to pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander people. So today we have a series of presentations followed by a panel session. So just to run through some housekeeping items, we're aware that internet connections on the online environment can vary. And if you experience technical difficulties, please feel free to put a question in the chat via the toolbar at the top of your screen, and one of our events team will do their best to assist you. And if you need to, feel free to leave the Teams platform at any time, and then you're able to rejoin without losing your place. If you'd like captions turned on via your Teams meeting settings, so click the three buttons on your toolbar and select language and speech, and then live captions. So we really encourage people to pop questions or comments in the chat throughout today. We will probably hold off addressing these until towards the end as part of the panel discussion, but as the question pops into your mind, feel free to pop it in the chat and we will be monitoring the chat. So to access the chat, look at the navigation bar and select chat up the top, and this will open a panel to the right-hand side of your screen where you can type your question or discussion item in the type a message box. So if we don't get the chance to answer all the questions popped in the chat today, we always follow up with people to provide answers and links to information afterwards. So do feel free to pop questions in the chat. So for today's session, you're going to hear from four presenters who are part of the core TRACE team. So initially, we'll hear from Professor Tim Geraghty, who is in fact the lead investigator of the TRACE program. And Tim will tell us a little bit about the background and the history of the TRACE program and the impetus for conducting the TRACE 3 program that we're talking about today. And I'm sure most people know Tim. He's the director at the Hopkins Centre. Tim will then hand over to Rachel Brough, who is a research fellow here at the Hopkins Centre, and Rachel will provide some details of the methods that we used in the TRACE program to collect data, and also she'll present some findings related to people with acquired brain injury. Rachel will then hand over to Emily Bray, who is another research fellow, and Emily will focus her presentation on people with spinal cord injury, as well as significant others. And then we will hear from Christy Hogan, who's also a research fellow, and Christy's going to share some really interesting latest findings from TRACE related to resilience and trajectories of resilience. So once we've heard from those four presenters, we're going to open up to a panel discussion. So we have some invited guests who are also part of the core TRACE team. So we have clinicians from Metro South Health who have been with us from the outset on this journey for TRACE. So they helped us design the TRACE program, and they're also helping us translate the findings into practice. So our panel discussion will focus on the significance and the relevance of findings for clinical practice. So without further ado, I would like to hand over now to our first presenter, Tim Geraghty. Thanks, everyone.
Thanks very much, Tamara, and welcome everyone. Those of you who know the Hopkins Centre would have heard about TRACE, heard the word TRACE many times in the past, probably. And as Tamara said, TRACE was one of the first programs of research that Hopkins set up, and we've been going in various versions ever since. So I'm just going to give you a very quick update of TRACE 1 and 2, which were the TRACE programs that led to this current work. Next, please. So you probably remember TRACE is a prospective longitudinal cohort, series of cohort studies in people with spinal cord injury and brain injury, where we've been looking at the effect of health service use, access to services, unmet needs, obstacles to services, as well as the way people transition through various components of care. And we wanted to look at the effect on psychological well-being, including anxiety, depression, stress, and stigma, as well as aspects of quality of life. Initially, we did that in the first 12 months of people being discharged from BIRU or spinal injuries unit at PA. And we've used longitudinal survey data linkage processes, spatial, geographic information, as well as qualitative methods to do that. You've probably seen this slide before. Just a reminder, TRACE 1 was the first iteration of this. Data was collected in 2017 and 18. There were 165 participants, and then TRACE 2 commenced in 2019. TRACE 2 data collection was cut short a bit by the pandemic, but 120 people were participated in TRACE 2, and you can see the various time points there. So discharge in 12 months, TRACE 2 also collected data at 3 months. Next. And just a very brief summary of the outcomes. So firstly, looking at care transitions. So we found multiple diverse and many complex care transitions that people had to go through as part of their early post-discharge period. We also found that people who perceived that transport was an obstacle early in that process, and that may have been associated with an increased total number of care transitions in that period. We did work looking at access to services to health services in Southeast Queensland, and these were not specific spinal cord injury, brain injury services. These were more general health services, and we found very variable access to services, and some places where access was very poor. Again, transport and also financial obstacles came up as a problem. Transport obstacles again came up when we looked specifically at issues for people with brain injury. And then financial obstacles was a recurring theme. It was found to be related to reduced health-related quality of life and increased anxiety in people with spinal cord injury, reduced independent living skills for people with brain injury, and there was significant out-of-pocket costs that people incurred with both the Medicare benefits scheme and the pharmaceutical benefits scheme, which was a significant cost burden for them. From a psychological perspective, we specifically did some work looking at the impact of stigma, people feeling stigmatized, and we found that was associated with increased psychological distress at discharge at 3 months and reduced community integration. And also increased stigma at 12 months was found to be associated with people who had lower function and were using a wheelchair. And finally, paid employment was found to be associated with increased participation, health-related quality of life, as well as reduced depression and stress. So that's a very quick overview of some of the key findings. Next, please, Christy, thanks. And so then that's the background to moving on to TRACE 3, which we're talking about today. So we wanted to continue to map and describe secondary complications, service access, and life stresses for people as they were discharged from inpatient rehabilitation. But what we really wanted to do in Trace 3 is to be able to look in more detail at how people were experiencing the discharge process and their rehabilitation supports, what were their personal expectations. And so in Trace 3, we've used in-depth individual interviews added to other data collection to really give us more detail about people's experiences. So that is a very quick bit of background, and now I'll hand over to Rachel Brough, who's going to talk more about the project methodology and data collection for Trace 3.
Thanks, Tim. And thanks to our team of academic, clinical and lived experience researchers as part of this Trace 3 project. We've just completed data collection for this third Trace study, which has a mixed methods longitudinal design. Surveys and interviews were conducted with people with brain injury and spinal injury over 5 time points from discharge to 2 years post-discharge. Tim just mentioned the aims of the project, with the key addition of this third study being the inclusion of qualitative interviews to have that more in-depth look into experiences and expectations. And that's really to help inform improved service coordination and individualised planning of rehabilitation. Out of 275 potential participants that were screened from PA Hospital, 126 consented and contributed to data collection at discharge. 125 participants completed the survey and 54 the interview. Over the course of the study, there was about 70% retention to the final data collection points at 18 months, where surveys were completed with 87 people and 24-month interviews were completed with 41 participants and 16 of their significant others. About half of the participants had a traumatic injury, and the majority of participants were male and lived in a major city. Surveys at discharge were typically done in the week before leaving hospital and were kept short at about 15 minutes long. As you'll know, it's a really busy time for everyone. Surveys at 3 months, 12 months and 18 months were longer and covered this broad range of topics. Like the surveys, discharge interviews were only 15 minutes long too. They covered expectations and priorities for accessing rehabilitation and support after discharge. The subsequent interviews at 3, 12 and 24 months were more extensive, covering more topics outlined here and lasting around 45 minutes to an hour. For the final interview, we also asked about life impacts, especially with respect to the stage of life the participant was at, as well as lessons learned. We conducted a qualitative study focusing on priorities, expectations and experiences following ABI. And for this particular study, we used the interview data from the 28 people with ABI at discharge and 24 at 3 months post-discharge. We were really interested in understanding the role that rehabilitation has in shaping those early self-perceptions and what impact it may have on adjustment process after ABI. Discharge and 3-month interview transcripts were thematically analysed using the framework method. These analyses revealed an overall theme of supporting self-continuity, which describes that sense of remaining connected to one's pre-injury self. And this overarching theme was comprised of these 3 interrelated themes of life's getting back on track, my life on pause, and collaborative fit, matching my needs. The first sub-theme of theme 1, my life's getting back on track, was addressing what's important to me, which was all about being able to participate in the activities and roles that made them who they are. At discharge, this was often phrased as getting back to normality. A stepped approach was often discussed where participants' priorities were to regain skills and functioning in everyday context to help participation in valued roles and activities. Returning to work and driving were often top of that priority list. The second sub-theme described the ongoing support that allowed people to keep improving their skills and function through therapies, but also having the formal and informal supports to fill the gaps, especially for tasks that they were not able to do independently. Overall, life was perceived to be on pause when experiences of post-discharge rehabilitation didn't align with participants' rehabilitation priorities and expectations of support. For the first sub-theme, participants perceived uncertainty, being unsure of what happens next, as some people describing experiences of discontinuity of services at transition points. Sub-theme 2 is about feeling restricted and gaps in support, sometimes expressed by being told, I can't do X, Y, Z, with subsequent losses of autonomy. A large focus was issues with transport for community access, illustrated by this second quote. I wanted to get home, but then I didn't realise that home was going to be my new prison. You're suddenly at home all the time. You lose contact or ability to have contact with your friends. You're on your own. You can no longer go and involve yourself in the world. Really capturing the meaning for this participant of how isolating not having reliable transport was for him. Collaborative Fit depicted the match between individuals' rehab priorities and expectations of life after brain injury and the nature of rehab services and support received following discharge. When participants had a flexible mindset and realistic expectations were matched with person-centred supports tailored to the individual, participants felt listened to and understood as a person with high collaborative fit. One participant described it as acclimatising to something new. Whereas low collaborative fit was when there was rigidity of thinking, such as being fixed on driving or working being the only thing that would help them resume life. When this was combined with the feeling that they were receiving a one-size-fits-all or generic approach rather than a personalised approach to support, things weren't going so well for them. So there are several implications for these findings. Firstly, when returning to driving and work aren't possible, in this post-discharge phase, it's important for self-continuity that people can participate in other valued roles and activities. Secondly, people with brain injury gain better understanding of the impact of their injury when re-engaging with their pre-injury activities, and this allows them to gauge their process. Therefore, the support offered by professionals in the home and community during this phase is really highly valued. And consistent with the previous 2 TRACE projects that Tim mentioned, we found again that lack of transport access was an obstacle to broader participation, which can negatively impact on wellbeing and lead to feelings of disconnection and isolation. More generally, the findings highlight to us the importance of person-centred approaches. Supporting people's continuity is pivotal during this phase of adjustment, and high collaborative fit is important because without it, people not only begin to disconnect from their identity, but also begin to lose trust with the people that are trying to support them. Here's a link to the publication of this study. And TRACE projects have shown that patients really highly value such a personalised approach to transitions to ensure continuity and tailoring of care to needs. There are 2 translation projects that have been informed by these TRACE findings that have just commenced this year. The first is supporting self-advocacy through a randomised controlled trial of the MySave program, and the second will involve planning and piloting the Project Buddies program, in which people with brain injury will be connected to Project Buddy facilitators to support their participation in personal projects. And now I'll hand over to Emily.
Thank you, Rachel. So I'm going to talk now about 2 other papers that we've written on using the TRACE data. The first one is called Setting Me Up or Holding Me Back, and you can follow that QR code to the paper. Next slide, please. So overall, the aims of this paper were to understand participants' priorities for rehab and the hopes and expectations for support post-discharge, and then explore how well these aligned with the experiences at 3 months post-discharge. It's very similar to that first ABI paper that Rachel just spoke about. Next slide, please. In terms of participants, all people with spinal cord injury who completed an interview at discharge or 3 months post-discharge were included in the analysis. We did a very similar analysis to Rachel's paper. And then from a demographic perspective, perhaps the only thing of note was that there's a slight underrepresentation in those with tetraplegia Asia A to C. Next slide, please. Here we have a diagram of the themes that came up through the analysis process. At the centre, we have theme 1, resuming life and what matters to me. This theme depicts individuals' rehab priorities, which focused on getting back to life and resuming the activities and roles they valued. At 3 months, participants acknowledged that it was often too early to have resumed some of these activities or roles, and they also spoke to how experiences post-discharge prompted them to reevaluate the assumptions they may have had about their recovery and priorities. Theme 2 at the top, Setting Me Up, depicted how coordinated and personalised supports received during the post-discharge transition period facilitated adaptation to life at home and in the community, and also helped participants address issues that arose. And lastly, theme 3 at the bottom, Holding Me Back, highlighted that some participants felt uncertain about their new life and the supports they would need, and that a lack of appropriate or timely supports hindered adjustment and progress with rehab priorities. So on the next slide, we have the key findings that arose through this study. The first key finding was that as people learned more about their injury and what meaningful progress looked like for them, it became clear that community-based mental health support was really essential for adjusting to life after a spinal injury. However, many participants said that this support was missing after discharge, mainly due to funding barriers, but also that complicated process of accessing subsidized sessions through the public health system. The second point is that participants felt satisfied when rehab supports actually helped them move towards their rehab priorities and solve problems as they came up. This worked best when health professionals took time to understand them, their specific needs, and provided tailored supports. Next, because many participants felt that they hadn't received enough information, there's a need for communication that is timely, repeated, and easy to understand. And then lastly, we found that factors like age and where people live increased their concern about whether rehab supports would be available often enough or for long enough to meet their needs. So I'm going to move on now to the second set of analysis we did, which really focused on significant others' perspectives of formal supports. And on the next slide, we have the aims of this paper, and that was to explore the experience of formal supports accessed by people with SCI and ABI in the first year after hospital discharge and the main barriers to accessing those supports. However, we were doing this from the perspective of the significant others. So participants in this analysis included all significant others that took part in an interview at 3 months and in 12 months post-discharge. And in terms of demographic, it really aligns with a lot of the caregiver literature. The majority were female, majority were spouses or partners, and in that 40 to 64 age range. On the next slide, I have a diagram that represents the 4 themes that arose from this analysis. And I'll go into detail of each theme now. So the first theme on the next slide is titled Journeying Along New and Complex Pathways. This theme highlighted that the early post-discharge period was complex and looked very different for each family. Some experienced smooth transitions, while others faced delays, disruptions, or gaps in services. However, despite this, overall, significant others generally felt grateful for the support that they had received. Theme 2, being on the same page through open and active communication, depicted how significant others' experiences with formal supports depended heavily on communication and information sharing. A key issue was the frustration that they felt when professionals appeared to overlook their knowledge about the person with the injury and also their specific circumstances when making decisions. Theme 3, titled Getting the Support Right, the Who and the How, spoke to the effectiveness of rehab support and how that was influenced by how well communication styles and support matched the person with the injury's needs. When the support was well matched, it not only helped the individual, but also eased the pressure and workload placed on significant others. And this leads nicely into the 4th theme, which was about becoming the safety net. So this really highlighted how significant others had to act as a safety net when formal supports or funding fell short, and they had to take on those additional logistic and financial responsibilities and prioritize the needs of the person with the injury over their own or other family members' needs. When it came to key findings, what we found was helping significant others understand how formal supports work, including the likely delays and the limitations of formal supports, may help them set more realistic expectations. Secondly, significant others want to feel heard, and they want their insights into the person's needs and their preferences to be recognized and also valued. Significant others also need emotional support themselves so they can maintain their well-being and then continue in their caregiving role long term. And lastly, significant others' expectations of formal support may not be met in the current climate, where the workforce face challenges due to stigma, low pay and conditions, variable training, and broader systemic pressures. So I'd like to kind of bring attention to two translation projects that are currently underway. The first one that is really addressing that need for participants to have access to information on spinal injuries, the healthcare system, and community supports, both prior to and following discharge. And this links directly with a seed grant that's currently being undertaken by Kelsey Chapman, where we are co-producing some resources for clinicians and people with spinal cord injury that are hopefully going to enhance that decision making and access to information in the inpatient setting. And that's currently underway, and some resources have been developed that look at supporting people with spinal cord injuries in understanding the questions that they can ask during the inpatient setting. And a second project is kind of talking to what Tim was speaking about at the very beginning, about vocational re-engagement and how that improves outcomes after injury. So what we'll be looking to do is develop a peer mentoring intervention with people with spinal cord injuries and healthcare professionals that's going to aim to enhance emotional well-being and self-advocacy skills during that process. So this is just started and we'll get underway this year. So thank you for your time. I'm going to pass over now to Christy.
Thanks, Emily. So this afternoon, I'll be sharing some preliminary findings about resilience after neurological injury. And with the introduction of positive psychology in the late 90s, there was a shift from simply alleviating negative symptoms to identifying and nurturing strengths, qualities, and factors that contribute to a fulfilling life and enhance overall well-being. And one such factor is resilience. So resilience is the ability to adapt or bounce back following adversity and challenge. Some argue that resilience is a dimension of personality that's relatively enduring and unchangeable. So you're either born with the ability to respond resiliently or you're not. Others argue that people only become resilient when faced with adversity, or that resilience is fluid and changeable, influenced by many factors like age, sex, socioeconomic status, etc. So resilience may be a stable trait, but equally it may be shaken. And when people are faced with adversity, resilience may be strengthened for one, but weakened for another, dependent on these influencing factors. So we know that after injury, people experience many significant milestones and stressors when transitioning back into the community. Last year, 2 honours students, Joyce Yee and Katie Mill, joined the TRACE team to examine Sentinel events and their impact on quality of life and sense of connection to the community. And core events included returning to work and returning to driving and independence in the home and community. Apologies for the light. So overall, there was a gradual resumption of roles and independence across all 4 core events, with more people experiencing these by 12 months post-discharge. Other significant events that people experienced in the first 12 months included financial strain, changes to relationships and living situations, difficulty accessing rehab, equipment, housing mods and care support, as well as changes in their leisure activities. So the impact core events had on increased quality of life and community integration was not dependent on whether the event actually occurred or not, but rather how people interpreted and appraised those events, whether that was positive, negative, or coping focused. So, for example, someone may or may not be able to return to driving, but if they believe that they're coping well with this, their quality of life remains high. Their appraisal and perceived coping is more important than the actual event itself. So this highlights the value of supporting individuals in how they make sense of those milestones or stresses by helping people reframe challenges, build coping strategies, and validate the complexity of their experiences. And perhaps people's resilience plays a role in their appraisals and their ability to cope. So only a handful of studies have examined resilience over time after neurological injury. Driver reported stability up to 3 months for people with SCI, whilst Lasoy reported stability up to 12 months post-injury in mild TBI. Marwitt similarly reported stability in a TBI sample, however, when controlling for moderating factors, concluded that resilience decreased over the first year. Despite the limited longitudinal literature, we know that higher resilience is associated with better mental health outcomes, greater community integration, and higher quality of life for both brain and spinal injury populations. So given the importance of resilience for positive outcomes, we were interested in understanding whether levels of resilience remained stable or changed during the post-discharge period. So the previous literature examined resilience at a group level, but we were more interested in identifying distinct resilience trajectories. So to do this, we measured resilience using the resilience scale 14 at discharge, 3, 12, and 18 months post-discharge. Using statistical modelling, we were able to chart people's resilience over time. So we can see here that at discharge, everyone had moderate levels of resilience, all above the population average. Then people showed variations in their resilience across 4 distinct trajectories. The first trajectory included the most amount of people, representing 63% of the sample. These participants had moderate levels of resilience that remained relatively stable from discharge to 18 months, with only a slight decrease between discharge to 3 months, sitting just under the population average. A quarter of the participants reported high stable resilience, slightly increasing after discharge and remaining well above the population average. So overall, 88% of our sample showed some level of stability in their resilience over time, in line with the previous research. The 2 groups showing variations in their trajectories were notably smaller. So 7% of our sample were in the decreasing stable group, who showed moderately high resilience at discharge, with a sharp decline at 3 months, followed by relative stability. These people were mostly younger males living in regional or remote areas and had a history of pre-injury substance or mental health difficulties. The last trajectory included 5% of our sample. These people showed stable, moderate levels of resilience from discharge to 3 months, followed by a steep decline at 12 months and a modest increase at 18 months. These people, again, were mostly younger, had the longest time since injury and higher levels of functional independence. And half these people lived in regional or remote areas and experienced pre-injury mental health difficulties. So it's important to note that for the last 2 trajectories in particular, which showed a decrease in resilience over time, each of these people were experiencing significant stresses at 3, 12, and 18 months follow-up. So this included things like financial or funding difficulties, personal or relationship changes, limited independence in the home and community, inability to return to driving, work or previous important roles, and mental health or health complications. So understandably, these events may have had an impact on someone's resilience. We've also started to look at depression trajectories over this time period and have found that those who had high or moderate stable levels of resilience were more likely to have consistently low levels of depression, further highlighting the importance of resilience for other outcomes post-injury. So we're hoping to continue to analyse these results and bring that to you soon. Overall, we found that resilience trajectories may remain stable for most people after significant injury. However, for others, they may experience fluctuations, potentially due to other external events occurring during the post-discharge period. This time period can challenge individuals' psychological resources as they're often faced with the impact of injury-related limitations in the home and community. Clinically, our findings highlight the importance of understanding people's long-standing ways of coping to be able to identify those at greater risk of declining resilience and increasing mental health symptoms during the transition period from hospital to home. An early identification would allow for timely and appropriate psychological intervention to be offered to these individuals to better support them. In the literature, there's also preliminary support for interventions targeting stress appraisals, positive coping styles, resilience-based approaches such as increasing people's sense of control over their care decisions, training problem-solving and self-advocacy skills, and creating opportunities for mastering and building a positive self-identity, as well as interventions targeting low mood. So thank you for providing me the opportunity to present these most recent findings, and I will now hand over to Tim and our panel.
Great, thank you, Christy. And perhaps you'll join with me initially and thank all our speakers today for some really interesting presentations, and everyone's kept fantastically well to time, so we'll have lots of time for the panel discussion and questions. Thanks very much. So we're going to move on now to the panel discussion. And we'll be putting our panelists to work a little bit, but we would also be very happy to get any questions from the audience, and we'll be taking as many of those as we can and adding them to the discussion too. So firstly, can I just introduce our panelists, many of whom you may well know. So Karen Watter, who's the manager of the Acquired Brain Injury Outreach Service, Rachel Jones, who's the CNC from the Spinal Injuries Unit, as well as a Clinical Research Assistant with the Hopkins Centre, Arati Kennedy, who's manager of ABI-TRS, and Melissa Kendall, who's a research assistant with TRP and ABIOS, all extremely experienced clinicians and clinician researchers. And thank you all for joining us today. And just a reminder, if there are questions, please put them into the chat, and we'll pick them up as we go along. So perhaps I will start by opening up the discussion to all or any of our panelists, and just start by asking you how you felt about the presentations, the results, how they resonated with your own experiences in your teams and service, and were there anything in particular that stood out for you? So does anyone want to volunteer to start, or?
I'll go.
Great, thanks, Arati.
I'll work because it might be a temporal sort of thing, given that our service works with people immediately post-discharge. So I think that that point that you had around collaborative fit, that's really important. I guess I feel we need to really harness that and work as clinicians to find what that means for any given person with injury and their families, and particularly for newly acquired injuries. We need to not only sort of work on that ourselves, but I think health clinicians in that early phase are in a unique position to then hand that on to the next group of people that are going to support those people on a long-term basis. And I'm mostly talking about support workers in the formal setting, but also those family members. And I think now that we've got a sense of the areas that are particularly important, we can actually proactively work with people across those particular areas. And then with our expertise, work to hand over what has worked and not worked just as importantly, because we hear time and time again people saying they have to repeat their story, or they have a bad experience and then they have another bad experience and another bad experience. If we can work harder to help those onward services with what's worked, but also importantly what's not worked with this person and their families, I think that's really important in terms of clinical design for health services.
Great, thanks, Arati. Does anyone want to add anything to that, or say something else? Karen?
Yeah, I'll add, because I think Arity and I were thinking on very similar lines to pull out that collaborative fit. And I think it's also that step of how do we as clinicians work with our clients and their families and that therapeutic relationship and alliance, and how do we build it? Are we making sure our people are feeling heard and they feel like they're getting their needs met through the rehab we provide? And thinking about how we can provide those personalised interventions, how we plan and do the things we're meant to be doing. And we know that takes time, and we know some of us don't work in a context that always makes that easy for us. So how can we actually reflect on what we're doing too, and maybe do things in a bit of a different way, or push some of those boundaries to try and meet those needs better. So that self-reflection on practice too, to keep growing what we can do. And my last comment on that collaboration is also that handover, that as Arity said, it's really important to be handing over those things to people and other services and support workers. But as things change in the community, those messages need to keep being handed over and not just be lost if somebody in that team changes. So that longevity of information provision and potentially some governance around that from our funding bodies would be a really helpful thing to help support that happening. Thanks, Tim.
Thanks, Karen. And Melissa or Rachel, from the spinal cord injury services, people with spinal cord injury perspective, did you have any thoughts?
Tim, I had some, a lot of those findings resonate for me on both levels, from an ABI perspective and a spinal cord injury perspective. I think the issue of like that transition period and the uncertainty that sits around that for significant others and for people with injury, and what we can do as clinicians to assist them, is really challenging, because I think the funding systems that we have are just constantly changing the goalposts. So for even clinicians to keep abreast of that space and what is happening and what is being funded and what the criteria are is hard enough, but then to have to communicate that to people in a way that makes sense to them and assist them along the way is equally challenging. Like, for instance, the recent changes in the My Aged Care system and the impacts that they're having for people with spinal cord injury, being discharged, with assessments being algorithm based now. So there's no discretion in how people are supported through that. Therefore, there's a lot of people staying in hospital because they're not being assessed as priorities going forward for support. So all of those impacts impact on us as clinicians in workload and being able to address it, but then have a flow-on effect to people with spinal cord injury and their families as well. And it's not just the My Aged Care system; it's all the systems. The goalposts are just constantly changing, and just trying to keep abreast of that is really, really challenging.
Yeah, I agree with you, Melissa, as well. And I have to say, part of the self-advocacy stuff is around actually teaching people how to speak funding body and how to actually approach funding body. And that's really hard from the inpatient setting, and especially, like you said, when rules keep changing and it's in a busy clinical environment, keeping up with those changes. We often rely on someone else to actually pass those messages through to us, so that then we can pass them through to the people who it actually really impacts and affects when they do go home. So obviously, I mean, we've all said the same sort of thing in regards to the most important things are collaboration, communication, but it's the communication that's like a constant stream of communication, which can become quite overwhelming for the person who's trying to adjust to this new life as well. So it is a very difficult sort of area to be in. But yeah, communication is probably the most essential part between all of the services, including your community care providers and support workers.
Okay, thanks, Rachel. So just a reminder, if you've got any questions that you'd like to ask any of the speakers or the panel, please pop them in the chat. So perhaps you've started to talk, or some of you have already sort of started to touch on this, but based on the results, some of the results that are starting to come through from these studies, do you have any thoughts about things that you would like to see done differently, or changes in practice related to some of these findings that might help address the unmet needs, or where there are gaps in support? I think everyone understands that it's a very complex area to be trying to improve for people.
Tim, I think the importance of psychological and mental health support is really reflected through these findings, and is something that probably isn't as well funded across the board as what it could be, or is quite variable in how it's funded. But I think really trying to strengthen those gaps in psychosocial support for people is really, really important, both from an inpatient setting as well as people move into the community.
Thanks, Melissa. And do you think that is the biggest problem that those services, that the appropriate types of services just don't exist, or that they're difficult to access, or people don't get referred, or is it a combination of all those things?
I think it's a combination of all of those things. I think the services are probably a little bit thin on the ground, number one. I think sometimes they're not funded, therefore people can't afford to access them. I think also people often have a mental barrier when it comes to psychological support. So it's even the person being ready to accept that type of support. So I think it's a combination of all of those things.
Okay, thank you. Arati, Karen, Rachel, anything sort of to add to that from the point of view of how this might help you think about different services?
Yeah, I'll talk to that. I think a couple of things. I think that the work that Christy showed about that resilience, I think that's really important, that self-appraisal and the enmeshing of that into whatever clinical rehab we're offering, is a really important component. And I think sometimes early on we perhaps focus a little more on gains, and we maybe just neglect that point around having people supported to have appraisal around their abilities and sit to then develop that resilience to this new way of life a little more. So I think sometimes I think that might be just giving clinicians the permission to kind of do a bit less and focus on that a bit more rather than the functional gains. And certainly there is pressure to keep those functional gains rolling, but I think we can also just ameliorate that with that resilience and coping around how things are without losing that hope. And I think then for a lot of people, we probably just need to agenda set, and that's okay, and that would be enough. And then I think for those that are struggling with that more, or it isn't resonating, that's when we need to have the opportunity to revisit that along the continuum. And then, as Melissa said, for those who can't embrace that and it's having a negative effect, we need that access to psychological support specifically for that group.
Thanks, Arati. Karen or Rachel, did you have anything to add on that topic? Otherwise, there's a question that I'll go to in the chat.
There's always something to add, Tim, but we're happy for you to go to the question in the chat.
Well, no, well, okay. Well, so, and it's not unrelated, so we can come back as well. So, Christy, you might have seen a question in the chat there, which is partly directed to you. So the question's around wondering if there's any data from discharge or 3 months regarding participants' early expectations of recovery timeframes and how that might map onto their resilience trajectory. And then also the second part is about further data collection, looking at resilience at the 2-year mark.
Thank you. So in terms of data from 3 months in discharge, we didn't specifically collect information regarding recovery timeframes. In the interviews, we did ask about people's expectations for services and rehabs and goals and stuff like that, but it wasn't in relation to recovery timeframes per se. And that was also a smaller cohort, a subsample of the overall people, which it was about a quarter of the people compared to the whole sample that we got the resilience data for in the surveys. So unfortunately, no, we didn't collect that. To answer the second part of the question, I don't think we have any current plans to follow up at the 2-year mark. We had previous TRACE studies had gone up to the 12 months and we've extended up to the 18 months. But we do know that that's a really important time as well, especially because people are coming around to that 2-year mark for like NISCU funding. So it's definitely a really important point, and I think we should consider that for future longitudinal studies. Yeah,
we just had the qualitative data for 2-year point for that about a third of the participants, and just about that, you know, in terms of early expectations of recovery timeframes. Some people did mention that as part of their discharge interview, but that was sort of recorded. It was a qualitative recording, not the quant, to be able to measure it specifically.
And not everyone would have offered that information as well.
No. But it did come up as, you know, part of the sort of expectations and things for people.
Great. Okay. Thanks, thanks, Christy and Rachel. And then so perhaps, Karen, I will come back to you then to see if there's just regarding practice changes in what we might be considering offering to people to address any or some of those perceived gaps.
And I think, Tim, I might bring in that support that we're providing to family members, whether that's significant others or children or that extended family networks, and how that's happening, and within the health service, how easy that is to do and what if that meets certain funding criteria. If you're on a tier 2 ABF funded pathway, you know that there are things that we want to support families with, and there are things that we know is best practice, but not always is there a funding mechanism for some health services to get reimbursed for that activity. So I think there's a bit of a discrepancy between old definitions of activity within health and what we should be doing and what we do and how we provide that. And just that, I think that at a system, like a big picture level, what are those, do we need a better understanding of what health outcomes are of that family and the values of that long term, not just to get people out of hospital, but, you know, if we're helping that family resilience and our significant others to cope with change and manage those things once people are home and manage that long term, what are the benefits of the health of that person and the person with injury and those bigger benefits that flow through, rather than go talk to Carers Queensland or seek supports through these other systems where it may not be specialised for what they need. So I think that could be an area of growth in health, outside of health just generally, and there's a big unmet need there. I have others, but I think I'll probably have enough.
No, I think that's a great point, Karen, and I think the importance of supporting family and significant others, you know, is something that we're becoming more and more aware of, but it is difficult, I think, often to provide it within existing resources, which are so busy just trying to do the basic, well, not the basic things, but the standard things. Whenever you try and add something else in, potentially there's a problem. Okay. So there's a question in the chat. How do you tackle patient-family resilience and the pressure of patient flow in hospitals? Anyone want to take a go at answering that one?
I'll have a go. We're a post-discharge service, so I'll say that at the outset. So the service I manage doesn't work at all with that pressure flow of, being the inpatient unit responsible for that admission. However, when we're a relatively new service for Queensland, and we were a 5-year research project from 2016 to 21, and when we operationalised the first ever transitional rehab service for moderate to severe brain injury in Queensland, research that led to our initial pilot project proposal has suggested that providing some sort of support to people with injury and their families before discharge was really important. And so we operationalised that by a formal in-reach period that we term. So we're a transitional service that goes in during the last 2 weeks of admission with and works with families and the person with injury to do a raft of initial evaluation measures, but also importantly to set the scene that you are coming out of hospital. We are going to work with you and your family thereafter. That's a very small thing, but I think a lot of these things, incremental change is what we can sort of make. And so now that here we are, 8 years later, and that's an embedded component. So now the discharging inpatient units expect that there will be some in-reach. And we've been able to leverage off the fact that our research out to 12 months post-discharge showed that people had better outcomes, and our qualitative research really actually had people saying how valuable that 1 or 2 visits before discharge was profoundly important for them. So I think, building some research and then building those operational ways of embedding it can lead to incremental change.
Great. Thanks, Arity. Okay, well, we're almost at time. So thank you very much to all our panelists and speakers. Some great discussion and questions there. And I will hand over to Tamara to close out the session.
Thank you, Tim. And on behalf of the Hopkins Centre, I just want to say a huge thank you to all of our presenters and our panel members. It's been such an amazing journey, and we are still well and truly on that journey. But TRACE is such a unique program of research in Australia, and it would not be possible without the involvement, collaboration and support of so many different parties. And I just want to acknowledge some of those now. So I'd like to thank the funding and support from NISQ for this program of research, and also Metro South Health in terms of all the in-kind support, encouraging their clinicians to be involved. And I also want to say a heartfelt thank to the participants. I mean, the number of assessments and questions that we ask people over that period of time, it's such a privilege for us to be able to conduct this research, and the time and generosity that people put in because they want the findings to contribute to change, positive changes for others, if not for themselves. So I want to finish today by really acknowledging our incredible cohort of participants, people with acquired brain injury and spinal cord injury, and also their significant others. And we are determined that these findings will drive changes and to improve the quality of care for people with brain and spinal cord injury. So thank you very much, everyone, for attending today's session, and I hope that you found it informative. If you'd like to get in touch with us or any of us involved in today's presentation, please do. The papers are very slowly coming out, so we're spending a lot of time now with data analysis and dissemination of the findings. So don't hesitate to reach out if you're interested in following up something that we discussed today. And thank you again for attending, and we hope that you have a great week. Thank you very much.